This morning, we're very excited to welcome Dr. Greg Serrao. Dr. Serrao received his medical degree here at Mount Sinai and completed his residency in internal medicine at Columbia's New York Presbyterian Hospital. He then returned to Mount Sinai for his cardiology and interventional cardiology fellowships, of which he was the chief fellow in both programs, and has been assistant professor of medicine and cardiology at Mount Sinai since that time. He's currently the director of mechanical circulatory support at our Cath lab here. Dr. Serrao is a key member of Mount Sinai's heart shock team who responded to cardiac arrests, cardiogenic shock, pulmonary embolism, and respiratory emergencies throughout the health system. He's not only an expert at the placement and management of percutaneous mechanical support devices, but also a highly skilled and devoted educator whom the house staff look to as a role model and a support system when taking care of the critically ill patients he serves. Very warm welcome to Dr. Serrao.
Thanks, Emily, for a very nice introduction, and thanks, Dr. Thomas and everybody for having me here to speak today. So as Emily mentioned, I'm one of the interventional cardiology attendings, and today we'll be talking about mechanical circulatory support, which is my focus. These are my disclosures, and I do have one additional disclosure. Francine sent me a very, very nice template to use for this talk, and I tried for over 1 hour to get this template to work for my slides, and I could not do it. So I'm sorry that I am not good enough at PowerPoint, but I'm going to switch to my slides because I could not get it to work. So give me 1 second. Okay, so this is what we'll be talking about today. So I think there's three main components of the talk. One is I want to talk about the importance of shock teams and what we did to develop the system here at Mount Sinai. I want to talk about the nitty-gritty, which is really the timing and the options available that we have at this time for mechanical circulatory support. And then also, what I think the future direction of mechanical circulatory support looks like and what changes may be had in the next few years. So first we'll start with shock teams. So this idea of a dedicated team that's meant to take care of cardiogenic shock at a hospital was really first introduced in just the last few years. And one of the main publications that led to the adoption of this system by many different health networks was this article that was published in JACC in 2019, which talks about standardized team-based care for cardiogenic shock. And what they did was they developed a shock team in 2016 at this hospital, and they identified 204 patients in cardiogenic shock following the development of this team. And they looked at historical risk match controls. So patients that were treated that were of similar level of illness before the institution of this team compared to those who were treated after the institution of this team. And they showed pretty exciting results. The blue line here represents patients who were in cardiogenic shock due to acute MI, and the red line represents patients who were in cardiogenic shock due to acute decompensated heart failure that's non-ischemic. So you could see for acute MI, there was a huge difference in survival, 44% before the birth of this team and 82% afterward. And there was a similar increase in those who had non-ischemic cardiogenic shock, an increase from 60% survival to 72% survival. So when this was published, a lot of people started to emulate this and think that their hospital needed it. And they published this strong conclusion, which is that a standardized team-based approach can improve cardiogenic shock outcomes, which is a historically very difficult condition to treat. So many articles came out following this about the idea of shock teams and doctors who specialize in treatment of cardiogenic shock. And the Journal of American College of Cardiology released this recommendation that talks about how shock teams should operate, who should they consist of. So they divided cardiogenic shock care into two groups because they're distinctly different. One being cardiogenic shock for acute MI and one being cardiogenic shock that is not related to acute MI. So acute MI related cardiogenic shock, the priority is to get the patient to the Cath lab. So for that reason, an interventional cardiologist is the leader of that team. And the interventionalist alerts the shock team and the rest of the team who takes care of these types of patients. Non-AMI cardiogenic shock is much different. The priority, it may be getting the patient to the cath lab for different reasons, but a lot more thought has to go into that decision. And for that reason, usually the shock doc, who's usually an advanced heart failure attending, acts as the coordinator of the team, and the rest of the shock team is activated as necessary. So, one of the problems with this was that it was only a single center that showed that these results were so significant. So additional studies popped up that reinforced the importance of this system. So this is a similar article that was published in 2019 from a different center, looking at the same thing, using a shock team to treat refractory cardiogenic shock. And they developed a shock team around the same time, which was 2015. And they did the same thing as the prior article. They identified 123 patients who were in cardiogenic shock after the implementation of this team-based system. And they examined the outcomes of these patients compared with historical risk match controls. And this is the Kaplan-Meier from their article. And what you could see is that the survival in the shock team cohort, which was the red line, was significantly higher than the control cohort, those that were treated by the system that existed before the implementation of a shock team. And this was looking at 30-day all-cause mortality, so significantly lower in the shock team arm than in the control arm. Another interesting thing that they highlighted in this article is that people who were against the idea of shock teams criticized the system in saying that if you have too many people involved in the care of these patients, it takes too much time to involve all those people, coordinate care amongst those people, and you end up just delaying time to definitive therapy, which is often mechanical circulatory support. So what they looked at was a secondary endpoint, which is called shock to support time, meaning the time when the patient started in cardiogenic shock until when mechanical circulatory support was successfully deployed. And there was no difference, which means that the use of a shock team did not lead to any negative aspect of care in delaying their care from involving multiple people. So this was, when this was released, again, many people started to emulate this, ourselves included. This was all released right around the time that I started here as an attending. And we developed a shock team based on this data. So we have 4 key members. From a physician standpoint, of course, the team is much bigger and includes nurses, ancillary staff, social workers, palliative care. But the 4 main attendings that make medical decisions in terms of how to manage the patients in cardiogenic shock are these 4 specialties: CHF for an advanced heart failure attending, an interventional cardiology attending, a cardiac surgical attending, and then a cardiac intensivist, one of our CCU attendings. And we developed a dedicated line through the transfer center that could be used both internally and externally to activate this team. So we have this number, 1833-MH-SHOCK. And when you call this line, the transfer center is able to rapidly get all 4 of these specialties on the phone. And similar to the way that was recommended in the JACC article, we have our CHF advanced heart failure attending acting as the team coordinator when the etiology of the shock is non-ischemic. And when the etiology of the shock is ischemic, the interventional cardiology attending becomes the team coordinator because, again, the priority is getting those patients to the cath lab. And we keep a protected bed that we can rapidly transfer patients to for purposes of treating for this condition. On the right side over here, I don't want to spend too much time on this. A lot of sister institutions and outside hospitals have asked for recommendations on when they should activate this line. So using some data that was published from Mass General, we gave some recommendations on when we think a patient might be sick enough to consider using this service. But we encourage everybody to use it because it's much better to be over alerted than under alerted. So we don't really emphasize this too much when we discuss this system. So next, I just want to go into the timing and options for MCS, which is the bulk of what I want to go through, which is, really what do we do from mechanical circulatory support standpoint when we get these patients? So the team that I think is deserves the most credit in the biggest move forward in the arena of mechanical circulatory support in the last 5 years is this group from Detroit that formed something called the Detroit Cardiogenic Shock Initiative. And the survival of cardiogenic shock has not improved at all since the advent of PCI. After the advent of PCI, there was a significant improvement in cardiogenic shock related to acute MI, and that was over 50 years ago. And since that time, the survival rates of cardiogenic shock have been consistently low and not improving. So this group identified that issue and said that there's got to be some way that we can develop a protocol that would improve survival from what it was 50 years ago. And they published this protocol, which is called the National Cardiogenic Shock Initiative, which is very dense. And I don't want to go through the whole thing here today because I think it's beyond the scope. But one thing I want to highlight is this is a table that shows most of the cardiogenic shock related studies that have been landmark studies in the last 5 years. And what this table shows is that when you compare the baseline characteristics of patients that were treated in these trials, they're very similar. So if you go through the table and you compare, age, use of inotropes, cardiac arrest, their vital signs, their lactate levels, they were all very similar amongst the 4 studies that have been published prior, and then also the cohort that was included in this National Cardiogenic Shock Initiative study. And what you could see is that the survival rate using this National Cardiogenic Shock Initiative was 72%. Versus much lower in the prior studies, despite having similar patient subsets. So this is what made a lot of people think that maybe this is something we should incorporate. And instead of going through the whole protocol, I just listed 6 things here that I think are the heart of this protocol that makes it as useful as it is and why it's effective. And I want to highlight 3 of those. That I want to talk about individually. So one is consistent use of right heart catheterization. The second is use of novel hemodynamic parameters from that right heart catheterization data. And these 2 novel hemodynamic parameters are called CPO, which is cardiac power output, and the other is called PAPI, which is the pulmonary artery pulsatility index. And we'll talk about those more in a second. And the third, and probably the most important, is early escalation of mechanical circulatory support if it's needed, with clear triggers to suggest when that is necessary. So first, I just want to talk about the SWAN. I know those of us that come through medical training, we're very lucky to spend time in our medical ICU or other ICUs where I think that this device has really fallen out of favor and gets quite a bad rap, actually. But I think it's very different when you talk about the use of this device, specifically in treating cardiogenic shock, and even more specifically than that, using it to treat patients in cardiogenic shock that are sick enough to require mechanical circulatory support. The additive risk of using this device when you have large bore arterial access for mechanical circulatory support is very, very small. And more data is coming now to suggest that the use of these devices in that specific setting lead to significantly improved patient outcomes. So this is an article that was published by that Detroit group using the Impella national database, looking at the use of right heart catheterization. And what you could see here is that if you go back and you look for those who had Impella implanted, how many of them survived to Impella explant, you could see that in the group that did not use a Swan GANS to guide that decision-making, 48% survived, while those who did use a Swan to inform that decision-making, 62% survived. And this was a unquestionably statistical significant difference between the 2 groups. And more recently, even more robust data than that has been released. And Dr. Garan in Boston, who was actually my senior resident at the time that I was training, but he is the head of heart failure now in Boston. And he published a study, a retrospective study of 8 centers looking at those who in cardiogenic shock. It was a sick cohort of patients. 84% of these patients had mechanical circulatory support. So highlights, the fact that we're looking at not just overall use of pulmonary artery catheters, but those specifically in the very sick subset of patients that are in cardiogenic shock requiring mechanical circulatory support. And some of these patients had right heart cath with partial data. Some had right heart cath with complete data, which is using all of these novel variables, and some had no right heart cath data at all. And what they showed very clearly is that in hospital mortality in those who had right heart cath with complete hemodynamic profiling was significantly lower than those who didn't. So I think this was a very important article that was published recently that really should be highlighted to remind everybody that pulmonary artery catheters are still important, especially in this patient subset. Now, like I said, there are some novel hemodynamic parameters that have been introduced in the last 3 to 4 years that have really made it easier to care for these patients and be more consistent in decision-making. So one of those is called cardiac power output. And cardiac power output is just a more robust variable that represents hemodynamic status. So one of the drawbacks of looking at just cardiac output in cardiogenic shock is that it doesn't take into account patients who may also be hypotensive. So cardiac power output is a variable that was designed to combine the two most important hemodynamic status parameters, which is what is the mean arterial blood pressure and what is the cardiac output. And you calculate cardiac power output by multiplying the mean arterial pressure by the cardiac output and divided by 451, which is just a constant that was calculated using the study where they validated this, which is not very important. But the important number to remember, at least from a resident and fellow perspective, is that a cardiac power output of less than 0.6 is a very important number to remember. And when you go back and look, some of the major trials that have been published, including the shock trial, which was published about 7 or 8 years ago now, this variable was the strongest predictor of mortality. And if you had a CPO that was less than 0.6, you had a very, very high rate of in-hospital mortality, 58% in that study. And for that reason, over the last 3 to 4 years, a CPO of less than 0.6 has been suggested as what should be a clear cut point of where we determine a patient's mortality to be high enough to justify the routine use of mechanical circulatory support if appropriate for other reasons. The second novel hemodynamic parameter is something called pulmonary artery pulsatility index. So up until just maybe 5 years ago, there was no option to provide right ventricular support in a percutaneous fashion. So we didn't really spend too much time thinking about what the right ventricular function is and if we should support it, because such an option didn't exist. But we'll go through in a few minutes that we're very lucky now that we have a couple of devices, at least two, that do enable us to percutaneously support the right ventricle. And when a device like that should be used either in isolation or in addition to a left ventricular support device is a very important question to focus on that could lead to better patient outcomes. And using a variable called PAPI, which is the PA pulse pressure divided by the RA pulse, the RA pressure. So just to write that out, it's the PA systolic pressure minus the PA diastolic pressure divided by the CVP. And there's been a number of different cutoff points that have been suggested for this variable. I think unlike CPO, where a 0.6 is the cutoff that most everybody uses, people use a different cutoff for PAPI. Most people say, though, that greater than 1 is what our goal is. And again, what we're using this variable to do is to determine, is the right ventricle adequately supported, or will this right ventricle, because of a low PAPI, require additional support dedicated specifically to supporting the right ventricle? So, this is a succinctly written protocol, but I think it is a complicated thing to think about and to use in clinical practice, but I tried to distill it down here for the purposes of just showing the main ways that we think about these cases. And calculating the CPO is often the first thing that we do. And like I said, using this 0.6 cut point has been a very effective thing. And using 0.6 as a time where we introduce left ventricular mechanical support is what we usually do. And in situations where we find a patient is not adequately supported, despite the use of what I call a starter left ventricular support device, you calculate the PAPI. And if the PAPI is adequate, meaning that it's greater than 1, it means that the right ventricle is actually doing okay. And the reason the patient might not be doing well is that the device you have in to support the left ventricle is not strong enough. On the other hand, if you calculate the PAPI and the PAPI is less than 1, it's usually the case that the patient is not doing well on the support device that you've put in already because their right ventricle remains under supported. So like I said, distilling down, I think, what's a complex topic, but just wanted to show you how those numbers are used in clinical practice. So talking about the options that we have for mechanical circulatory support, I divided into 3 categories here. One is the initial options, the ones that we use where we really don't think too much, honestly, because at this point, we are very comfortable using these devices. We can deploy them quickly and usually without complications, and they can be easily managed in the ICU. In the other 2 categories are devices that I have listed under LV escalation and devices that I have listed under RV escalation. So the LV escalation devices are devices that you would use in specific circumstances where, again, you've put one of these initial options in and the patient is not doing clinically well, and you believe the reason is because the left ventricle is undersupported rather than the right ventricle being undersupported. The right ventricular escalation devices are devices that you would add when you think that the patient is not doing well because the left ventricle is adequately supported, but the right ventricle is not keeping up. So we have a lot of different options available for each of these situations. So I just want to go through each of them. Many of you have seen them before if you've rotated through the ICU, but we don't always get time to sit down and talk about the specific benefits and drawbacks of each of these devices. So I just want to do that quickly. So the intra-aortic balloon pump is the device that has been around for the longest. It's the cheapest, it's the quickest to deploy, it's the easiest to deploy, it's the safest to deploy. But when people talk about intra-aortic balloon pump, they don't like to say those things anymore. They like to say that data has shown that intra-aortic balloon pumps don't necessarily help in the setting of acute MI, or they like to talk about how intra-aortic balloon pumps don't provide that much support. But from a anecdotal perspective, and when you look at the data for intra-aortic balloon pumps, not in acute MI, but in other types of cardiogenic shock, it's still a very, very effective tool. And like I said, most importantly, it's cheap, it's easy to use, and it's usually free of risk. So we still like this device a lot, and I know those of you that have rotated through the CCU see it used often. So the flow that you get from this device is not a lot, it's true. It's about 0.5 liters per minute in addition to what the patient has without it. But its sheath size is relatively small. For patients, for people that have training in large bore arterial access, the 7 to 8 French sheath is pretty small. It's just a little bit bigger than what we use for a standard PCI. And the way that this device works is by using counterpulsation in the descending aorta. So the balloon sits in the descending aorta with its tip just at the start of the arch. And during diastole, this balloon inflates, and during systole, the balloon deflates. And in diastole, when the balloon inflates, it helps because it pushes blood into the coronary arteries to better perfuse the heart, which, as you remember, is done in diastole. And in systole, the balloon deflates, creating some suction effect, which pulls blood forward and helps to augment cardiac output, decrease afterload, and where the main benefit of the intra-aortic balloon pump comes from, this deflation in systole. And what you can see here at the bottom is a picture of what the catheter looks like. This is the part that goes into the body, and this part from here to here is actually where the balloon sits. So relatively small device that we think does a good job at adding to standard medical therapy without incurring much risk. The Impella CP at this point, I think, has become standard of care for a lot of cardiogenic shock, especially in the Cath lab, especially in the setting of acute MI. And I think that there were a lot of complications from this device when it was first released, but we've become a lot better at using it. And for that reason, it's being used more now, effectively and safely. And the way that this device works is that it's a catheter that has a motor on it. And it goes in through the femoral artery usually, goes across the aortic valve and sits such that one piece of the catheter is sitting inside the ventricle and the other piece of the catheter is sitting in the aorta. So this is a close-up picture of that pump here on the left. It's upside down compared to what it is inside the heart. So inside the heart, this pigtail sits at the left ventricular apex. This part is the part that sits inside the ventricle, and then this part is the part that sits at the aorta. So what happens is that this pigtail here actually doesn't do much. It just prevents the catheter from injuring the left ventricle while it sits inside of it. But this is a port that sucks blood, and then the motor sits in this catheter, and then the blood is spit out of this area here, which is in the ascending aorta. So this device provides a lot of flow by sucking blood from the left ventricle, spitting it into the aorta, and therefore moving blood from the left ventricle to the aorta independent of left ventricular function, and therefore providing left ventricular mechanical circulatory support. So it provides a lot more flow than the balloon pump does, it's true. This provides up to 3.5 liters per minute of flow, which is a lot of flow for a patient in cardiogenic shock. The downside is that the sheath size is a lot bigger. So compared to the 7 French balloon pump, this is 14 French, so double the size. And for that reason, the vascular risk is much, much higher, more than double the vascular risk. But the concept is an important one of pulling blood from the left ventricle and injecting it into the aorta. And this has a lot of benefits that leads to the successful use of this device. But sometimes 3.5 liters per minute is still not enough. And for that reason, Impella recently released devices that flow more than 3.5 liters per minute. And so one of the devices that they've released recently that we use often is called the Impella 5. And as its name suggests, the flow of this device is 5 liters per minute. As opposed to the Impella CP, this sheath size is even bigger. It's 23 French, which is a very, very big percutaneous arterial access. In fact, prohibitive size percutaneous arterial access. These devices are put in conjunction with a surgeon. We often work with Dr. Anyanwu and Dr. Itagaki, who provide such support for us by putting vascular grafts, allowing us to put these devices in. It works using the same concept, pulling blood from the left ventricle and ejecting it into the aorta. And this device is a really effective device to use. I listed at the bottom here in a patient who has severe cardiogenic shock, where Impella 3.5 may not be enough, but the patient does not need right ventricular support because this device does not do that and only supports the left ventricle. So we use it in patients who have severe cardiogenic shock with a normal right ventricle. And as a person who went through medical training like all of you and not through surgical training, it was a little bit hard for me to picture as a trainee what exactly is meant by inserting a device through a surgical graft. So I just wanted to include a couple pictures here. This is Dr. Itagaki, one of the junior cardiac surgeons who I work with all the time. And what these pictures show is on the left-hand side, he made an incision over the right shoulder, and he's exposing the axillary artery and putting some ties around the axillary artery to control it. And this here is a Dacron graft, and he sews this directly onto the artery so that it provides an access point to the artery without having to percutaneously access it using the Seldinger technique. And once this graft is in, instead of putting this big sheath inside the artery, we could put this big sheath inside the graft, which is a huge benefit because it removes the risk of placing it, but also allows blood to still go down the arm by avoiding this very, very large bore sheath that may block blood flow when it's placed inside the axillary artery. And once this sheath is in place, we place the Impella in a similar way to the way that we would in the cath lab through the femoral. We just do it through this sheath instead under an X-ray machine. And the benefit of using axillary access is multiple. But one of the biggest things is that when you have a patient on mechanical circulatory support, ICU care, rehabilitation, mobilization are things that we know that significantly improve survival and reduce morbidity associated with the use of these devices. So having axillary access, especially for a patient that you think is going to be on support for a prolonged period of time, more than, let's say, just 2 or 3 days, the ability to have this device in place using the axillary artery as opposed to the groin lets the patient mobilize. So this is actually a picture of the first patient that we used the Impella 5.0 on in our ICU here. I'm sure a lot of the residents in the audience were involved in this case. It was a 70-year-old gentleman who had a large anterior wall MI that was insufficiently supported using an Impella CP, and we escalated to this device. And it was in for about a week. And this is actually just post-op day 1 from the placement of that device. And he was able to walk around the ICU, which really helped him recover in the way that he did. Because of the success of the 5.0 device, I guess Impella is getting a little bit lazy with their names. They're not quite as sexy anymore, but Impella 5.5 is the new device that they've released. But confusingly enough, Impella 5.5 flows 6 liters per minute, go figure. But they were able to develop this pump that has a couple of advantages compared to the Impella 5.0 pump. One, I've already mentioned that the flow is significantly higher, so another liter per minute of flow compared to the prior. Its sheath size is a little bit smaller. This is not that significant because it still requires the same procedure that I showed you before, which is the insertion of an axillary artery graft to place it. But the way that they have improved the ICU care is by adding a special sensor on the pump that does a better job of telling where the pump is positioned. So, one of the most memorable things from my residency and fellowship is that whenever these devices in, as a fellow, you're not going to be able to sleep because you constantly have to use echo to ensure this device has not migrated. It's still in the appropriate position, and it's still providing the support in the correct way. You can't really tell that without an echo still on the Impella 5.0. So with the addition of this optical sensor, the device does a much better job being able to tell where it's positioned and if it has migrated, and alerts you very quickly if that has happened, and tells you how to fix the device based on the way the migration has happened. Either has it been pushed too far into the ventricle, has it been pushed or pulled too far out of the ventricle, and it really makes ICU care a lot better. We don't use this device much here anymore because honestly, it's cost prohibitive at this point. But hopefully at some point in the near future, Impella will come to its senses and reduce the cost of this catheter, and we will start to use it here at Sinai because I do think it has several advantages. TandemHeart is a device that we don't use much anymore. It works a little bit differently than the Impella. So the way that the TandemHeart works is that it requires both venous and arterial access in the groin. And through the venous access point in the groin, you insert a sheath into the femoral vein, up the IVC, and you use a technique called transeptal puncture, which is putting a wire across the intra-atrial septum, so going from the right atria into the left atria, and then you pass this cannula through that hole so that the tip of the cannula, even though it entered in the venous system, now sits in the left atria. And you also put a sheath into the femoral artery. And the way this device works is it pulls blood from the left atria and ejects it into the femoral artery. So it's moving blood from the left atria to the arterial system distal to the left ventricle, and therefore provides a way for the blood to get from the left ventricle to the aorta independent of left ventricular function, and therefore providing left ventricular mechanical support. So it does flow pretty high. It flows between 4 and 5 liters per minute. The sheath size is also significant, but not quite as big as the Impella 5, so it still can be done percutaneously. It usually requires about a 21 French femoral vein and a 17 French femoral artery. And just to put some numbers in your head that helps you understand, what these numbers mean in terms of French, a standard triple lumen catheter is 7 French, and a standard dialysis line is 11 French. So these are much bigger than those, and some of them are going into the artery, so they're quite big. And like I said, the way it works is that it pulls blood from the left atria and ejects it into the femoral artery, providing left ventricular mechanical support. We don't use this device anymore. In fact, we haven't used it at all probably in the last 3 to 4 years. The only times we do use this is that if we have a patient who had a recent aortic valve replacement that needs mechanical circulatory support, we still prefer this device. And the reason for that is that the Impella device has to sit across the aortic valve. And when the Impella device sits across the aortic valve, and when it moves across the aortic valve, it can damage recently placed bioprosthetic and certainly a recently placed mechanical aortic valve. So the Impella devices we prefer not to use in that situation. And if we're not using an alternative device, TandemHeart is a good option in that situation. But again, very, very, very rarely used, but I wanted to include here for the sake of completion. RV support devices, I mentioned, are a novel introduction to our arsenal in the last 5 years. As I mentioned, there were not options for right ventricular mechanical support prior to the introduction of these devices. And the introduction of these devices have helped us, but also given us a lot more to think about in terms of what devices we should be using when and in what combination. So I won't spend too much time talking about that, but I wanted to tell you about the 2 main devices that we use to support the right ventricle percutaneously. One of them is called Impella RP, which is a device that was released by Aviomed that's meant specifically to support the right ventricle. And the way that this device works is that it's inserted through the femoral vein and sits up in the pulmonary artery. And it has a pump very similar to the Impella CP, where there's an inlet here that sits in the IVC, and it sucks blood from the IVC, and then the motor pressurizes the blood and sends it into the pulmonary artery. So this device is moving blood from the inferior vena cava to the pulmonary artery, independent of what the right ventricle is doing, and therefore providing right ventricular mechanical support. So the device is relatively big. It's a 23 French vein that's inserted femorally. And we have used this device several times in the last few years. After the market release of this device, the follow-up data was not as strong as the initial data that was given to the FDA for approval. So we use it sparingly, honestly, but it still does have a role and does allow us to support the right ventricle specifically using a percutaneous approach. Our preferred device for right ventricular mechanical support at this point is a little bit of a different one, which is called Protect Duo, which is TandemHeart system to support the right ventricle. And this is a 31 French cannula that's inserted into the right internal jugular vein. And it has a very, very nice design that allows it to curve in a way such that it's inserted in the jugular vein. It's a double lumen catheter. The way I like to describe it is that it's just a massive Shiley catheter. Operates the same way. There's two lumens. One is a port to suck from and one is a port to return to. And the port that you suck from sits in the right atrium. So it's pulling blood from the right atrium, and then it goes through the machine, it's pressurized, and it's inserted into the pulmonary artery. So again, moving blood from the right atrium to the pulmonary artery, distal to the pulmonic valve, independent of what the right ventricle is doing, and then therefore providing right ventricular mechanical support. So very, very big device, but because it's venous, it usually can be done with a good safety profile, and we've used this device with good results in the last few years. ECMO is the last device that I'll mention. ECMO is a very, very powerful device, but requires a lot of training and team coordination to use and select when to use. So we do this on a team-based approach for every case that we use it for. The way that ECMO works is that it's two cannulas, one's inserted into the femoral vein and one's inserted into the femoral artery. And the catheter that's inserted into the femoral vein goes all the way up and sits so that its tip is in the right atrium. And then the arterial cannula sits down in the descending aorta. And the machine sucks blood from the venous system, puts it through an oxygenator, which adds oxygen to it, removes carbon dioxide from it, puts it through a motor that pressurizes it, and then inserts it back into the femoral artery. Now, because you're sucking blood from the right side and returning to the left side, this is the only single device that we have that supports both ventricles, the right and the left ventricle, which makes it particularly powerful. Also, its flow rates are the highest of any device that we have. It can flow up to 7 liters per minute based on what sheath size you choose to use. But the downside is that it's a very complicated device to use and the sheath size is large. So our standard sheath size that we use for this is a 25 French vein and a 17 French artery. So quite big. And like I said, pulls blood from the venous system, puts it through the system, and ejects it into the femoral artery. And one of the good things about this is that, don't get me wrong, it's very complicated to insert because it involves the use of these very, very large size sheaths. But it's not being inserted across the intra-atrial septum, or it's not being inserted across the aortic valve. So you don't need fluoroscopy to deploy this device. So for the sickest patients where you're at the bedside and you need to do something to save life, this is definitely the preferred device because it could be inserted quickly. It provides a lot of support to both ventricles and to the lungs and can be done without the use of fluoroscopy. So for that reason, this is still a device that we like very much and we do use a lot of in both the CCU and the CTICU. Again, in a team-based fashion with the cardiac surgeons. So now that I've introduced what the devices are that we use now, I want to spend a little bit of time talking about what I think the future of mechanical circulatory support is going to look like in just the next 3 to 5 years. So one of the most important studies that I think is going on now is something called Door to Unload. And it's being run out of Boston by Dr. Navin Kapoor. And what the Door to Unload study is looking at is right now, when a patient comes in with ST elevation MI, the priority is getting the interventional cardiologist, moving the patient to the cath lab, and putting devices across the occlusion in the coronary artery to reestablish blood flow in the quickest way possible. And many of us know that we shoot for a 90-minute door to balloon time, and we've even more recently now started aiming for a 90-minute first medical contact to balloon time, just trying to open up the artery as quick as possible, thinking that that is going to, improve outcomes in this subset of what could be very sick patients. But what this study is saying is, maybe we're doing it wrong. Maybe rushing to open the artery is not what we should be focusing on. And instead, what we should be focusing on is restoring appropriate hemodynamics, both the blood pressure and left ventricular filling pressures. And maybe by doing that before we revascularize, we can improve outcomes. And though a little bit of a confusing idea and definitely a controversial idea, there have been animal studies and pilot human studies that have been done that has shown that it's at least not less safe than our current approach. So they have received authorization to do this randomized study, which we are a site participating in and will be enrolling patients soon for. And what it's going to do is it's going to take patients that have anterior wall ST elevation MIs, and they're going to divide the patients into two subgroups. One is going to be a subgroup who receives standard of care, move the patient to the cath lab as quick as possible, open the artery as quick as possible, and support with mechanical support as necessary, but not as a priority. On the other hand, this door to unload group, the experimental arm in this study, is going to instead prioritize mechanical circulatory support placement rather than PCI. And the way that they're going to do that is that they're going to place an Impella CP and let the Impella CP decongest the left ventricle for 30 minutes prior to reperfusion. And this is a really hard concept for interventional cardiologists to accept, that we're going to put this device in and then watch an occluded artery for 30 minutes before we open it. But like I said, safety studies have shown that similar to the ways that, giving a rush of blood flow and oxygen to the brain after cardiac arrest can trigger a reperfusion injury and actually make things worse, the same thing can happen to the heart, and rushing to open the artery and providing robust blood flow can cause myocardial reperfusion injury. And the other thing is that if the left ventricular end diastolic pressure is very high, sometimes after you place a stent, the ventricular pressure is so high that you have poor flow through that stent, and you can have complications as a result. So these are the two main reasons that people think that this concept is important to look into, and this randomized study will answer the question of maybe this is what we should be focusing on in the sickest subset of patients with anterior wall MI. So we do expect the results of these studies in the next 3 to 4 years. But if this study is positive, which, at least the initial data is looking like it might be, I think it will lead to a significant shift in the way that we treat anterior wall MI, and will be a much different way for us to take care of these patients. So we all look forward to this and look forward to the way that it impacts care, especially in the realm of mechanical circulatory support. The second topic that has already started to explode, and I think will continue to explode in the next 5 years, is a concept called ECMO CPR. And what ECMO CPR is it's the emergency deployment of VA ECMO during cardiac arrest with CPR in progress as a way to immediately restore systemic perfusion. And similar to prior, there was a lot of theoretical benefits to why this may work before it was actually looked at. So we all have done CPR at some point in our training, and we know that CPR is kind of hard to do. It's exhausting to do, and even as a trained subset of people, highly trained subset of people, sometimes we provide inadequate CPR just because of the drawbacks of CPR itself. So ECMO is a more reliable way to artificially circulate blood around the body when the heart is in cardiac arrest, as compared to conventional CPR. And the thought is that the quicker you reestablish some form of circulation, artificial or not, you will limit end organ injury that comes from a cardiac arrest, and you will decrease the chances of a patient having brain death. And furthermore, in addition to CPR just not always being effective, even when it's done by a trained subset of providers, definitely what we found is that prolonged CPR is not a good thing. And, we have all been part of resuscitation teams, and I'm sure we can all think back and remember, which is shown in this graph, is that, if you're going to get a good outcome from conventional CPR, it's going to happen quickly. And 80% of all patients that are going to achieve ROSC from conventional CPR, it happens within the first 15 minutes. And 95% of patients that are going to achieve ROSC happen within 30 minutes. So, past 15 and definitely past 30 minutes, continued resuscitation using conventional CPR is very unlikely to be effective if it has not been effective already. So this is another reason that, this begs for another option in these circumstances in a select subgroup of patients that, really should not be having cardiac arrest, someone that was prior healthy. And the third thing is that once a patient is on ECMO, you could focus on identifying and treating a potentially reversible cause what put the patient in cardiac arrest to begin with. And the reason that interventional cardiologists and cardiac surgeons focus on this so much is because the two most common reversible reasons for cardiac arrest that can be rapidly treated are acute MI and pulmonary embolism. And we can use, percutaneous coronary intervention or pulmonary thrombectomy or embolectomy, either percutaneous or open. And doing these things enables the heart to get better and the patient to recover if it's done quickly and effectively. So, in addition to just having theoretical benefit, this has clear proven randomized trial benefit. So there's a group in Minnesota that's led by an interventional cardiologist who I personally idolize. His name is Dimitri Yiannopoulos. And he and this guy, Jason Bartos, developed a team of interventional cardiologists at the University of Minnesota that focus specifically on treating patients in cardiac arrest and specifically treating the subset of patients in cardiac arrest due to acute MI. And what they did was they developed a protocol that went against the standard of care. So the standard of care, which is the way it's here now and the way it is for most, is that if a patient has a ventricular fibrillation or ventricular tachycardia arrest outside of the hospital, the way that EMS operates with good reason is that they spend a lot of time in the field trying to resuscitate the patient and shock the patient out of ventricular fibrillation, because transport in an ambulance during cardiac arrest is definitely suboptimal. And usually you're unable to do adequate CPR during that transport. And for that reason, you spend as much time in the field trying to resuscitate, because the thought is you're going to take the risk of putting the patient in an ambulance, do subpar resuscitation to rush the patient to the hospital where not many more options are going to be available than what are available in the field with paramedic. But since the idea of ECMO CPR has come up, this is a significant thing that could be offered at the hospital that is not being offered in the field. So what they said was, instead of spending all this time in the field trying to resuscitate refractory ventricular fibrillation, when you identify refractory ventricular fibrillation, stop messing around, put the patient in the ambulance, get the patient to the hospital as quick as possible, and we will put the patient on ECMO when they get to the hospital and then figure out what to do from there. So they have two groups here. This was the first study that they released that was a historical-based control. So they compared what happened to the patients that they used this protocol for versus what happened to the patients that did not have this protocol and used the old protocol of trying to resuscitate in the field and then being brought to the emergency room and trying to resuscitate there. And what you could see is that when they developed this protocol, they had a very impressive survival rate of 45%. And this is neurologically intact survival, 45%, as compared to 15% in the group that was treated with the old protocol. So when this study was published, it gave impetus to start a true randomized control trial, which was the first randomized control trial ever for ECMO and one of the most robust for mechanical circulatory support in general. And this study was just released in November of this year. It's called the ARREST trial, which stands for Advanced Reperfusion Strategies for Patients with Out-of-Hospital Cardiac Arrest and Ventricular Fibrillation. And what they did was they took 36 patients who they identified as refractory ventricular fibrillation, which they defined as 3 shocks in the field and 300 milligrams of amiodarone remaining in ventricular fibrillation. And they randomized them into 2 groups, one being the old system, try and resuscitate them in the field, then bring them to the emergency room, try and resuscitate them there. And if you effectively resuscitate and they have an ST elevation MI, then they go to the cath lab and get revascularized as necessary. The experimental group was, as soon as you identify refractory ventricular fibrillation, let us know. We will activate the cath lab. you will bring the patient directly from the field, bypass the emergency room, go directly to the cath lab. The patient will go on ECMO and we will do PCI. And they showed very impressive data. In the conventional group, only 7% survived, while 43% in this experimental eCPR group survived. And while this trial was meant to be much larger and take much longer, an interval analysis of the data showed that the benefit of the experimental group was so strong that the institutional board could not allow the study to continue ethically and not offer this treatment to patients in the control arm. So this was very exciting data when it was released. And I think it's going to definitely become the future of cardiac resuscitation care. So these are just my views that are already starting to happen and which I think will continue to happen. And one is that ECMO will become the standard of care for cardiac arrest related to ventricular arrhythmia. And it's something that we're using more as an institution now, and other centers are doing the same. Hospitals will be designated as cardiac arrest receiving centers the same way that we're designated as stroke centers or MI centers. And this is already happening. We're actually meeting with FDNY on a regular basis to develop a protocol for when patients like this will be sent to us or to a select group of other hospitals that have the availability to do ECMO 24/7. We will have a new metric, I think, for cardiac arrest, which is called door to needle, which is a metric that Dr. Yiannopoulos brags about, which is, as soon as the patient gets through the door, how quickly can you get them prepped and start percutaneous access for ECMO for the purposes of resuscitation? And like I said, we're already doing this and we'll continue to work with the EMS system to prioritize rapid transports during cardiac arrest in favor of doing that rather than keeping them in the field and continuing to attempt resuscitation when it seems futile. And even more forward-looking, this idea of, well, why do we need to even bring the patient to the hospital at all? Why can't the hospital bring ECMO to the patient when they're in cardiac arrest? And even though it sounds crazy, it's something that is already being done and has been being done for years in Europe. This is a picture of a museum in France with a patient in cardiac arrest being put on ECMO on the floor. This is a patient in the subway station in France being put on ECMO on the floor because they were unable to be resuscitated. And now this is starting in the United States. So that same group led by Dr. Yiannopoulos, they bought this fire truck. Believe it or not, this is a truck with a fully functional cath lab inside with a fluoroscopy machine, an ECMO machine. And they drive this truck to usually like a grocery parking lot where they meet EMS, who has a patient in cardiac arrest, and they move the patient to the truck, and using fluoroscopy, they put the patient on ECMO, and then they bring the patient to the hospital and they do PCI. So anything that they can do to cut down the cardiac arrest time will lead to even improved patient outcomes compared to what they are now, is the theory. And the next study that they published, I think, is going to be looking at this specifically and also has the potential to really lead to a novel improvement in the care of cardiac arrest. So with that, I'll stop. And thank you all again for inviting me here, for listening, and for tolerating my personal PowerPoint template that is required by Dr. Sharma when we make any presentations. So thank you all again, and I'll take any questions.
Thanks, Greg. That was a great update. There are some questions in the chat already, comments.
I'm bad at looking at that. Let me see if I could find it.
I can read them if you know.
Okay, let's see here.
Yeah.
One question was, why are octogenarians excluded from the cardiogenic shock initiatives? So we don't treat it as a strict criteria, but use of these devices, they're very resource intensive. They're very expensive. There are some decisions that you need to be, there are some patients that you can't use it on. And, unfortunately, age is one of the ones that we know is closely correlated with outcomes and something that's rapidly being able to be assessed and used as a cut point. So there is an age cutoff that has to be made. I'm not sure what the right one is, and I admit that. But I do think an age cutoff has to exist. Another question was, how long does it take to insert ECMO? This is very operator and patient dependent. So, our average cannulation time here is somewhere around 10 minutes. Dr. Yiannopoulos, he's been doing it for even longer and uses fluoroscopy to guide his insertions. his average insertion time is around 6 minutes. So it can be done very quickly, but it takes a lot of training to be able to do it that quickly and safely. So that's what our team has been focusing on. Another question was the cost of these devices and DRG payments. So yes, so the way that hospital reimbursement works for patients that are this sick is that there's a bundle payment that comes that is what the hospital is given to take care of these patients. For most insurances, we have to then pay for the device out of this bundle payment. So the more expensive the device or the more number of devices that you use, the more that you eat out of the DRG that the hospital gets. And none of us here are doing this for profit making or anything, but obviously the hospital can't lose money on all these cases, otherwise we won't be able to help others. So cost is something that we do need to keep at the top of our minds in order to support the sustainability of the program. And one last question here was, what's the risk of Impella insertion and what % of cases it can happen? The main risk with any large bore arterial access insertion is vascular injury. And what % of the cases that it happens, I think that's very center specific. Now that we do structural intervention where we're used to dealing with large bore arterial access, I think it's much lower. I would say on the realm of 5% risk of vascular injury in the hands of an experienced operator, but it's not 0 and it's not 1. So it does happen. So.
Since Greg's not going to read it, I'll read it also. There's a comment saying, great talk and thank you for all your hard work in keeping us on the cutting edge. So since he's not going to say it, I'll say it because it was great to see what you're doing and what our cardiology division is doing for this really important work. So thanks, Greg. Really appreciate it.
Yeah. And thanks for having me. And I do need to thank the cardiology division, Dr. Sharma, Dr. Kinney, Dr. Fuster, and also the cardiac surgery division, Dr. Adams, Dr. Ani, who have given a lot of support to this program and really have allowed it to grow in the way that it has. So thanks to them and thanks to you.
Great. Have a nice day, everyone. Thanks for coming to Grand Round. See y'all soon.